Hello and welcome to Webinar Campus. Today is a special edition of Webinar Campus because we have very senior academicians hosting this webinar. This will be Trauma Anesthesia Module 1 in Webinar Campus. Today we are fortunate to have a moderator from India's prestigious institution, All India Institute of Medical Sciences. It's none other than Dr. Gyanendra Pal Singh, who is additional professor, Department of Neuroanesthesia and Critical Care, AIIMS, New Delhi. I welcome Dr. Singh to take over the proceedings, and I remind all the participants that there will be interactive questions in between. So your participation is most welcome. That will make this session more meaningful for each one of us. It's over to you, Dr. Singh.
Thank you, Dr. Shashidhara, for that kind words. And good evening to everyone. A very warm welcome to all the participants for today's webinar. As most of us are aware that we are holding this webinar for two important topics. These are the traumatic brain injury and anesthesia for fractured neck of femur. Right? So these are the topics important not only for those who are appearing for the exams, university exams, but for people who are practicing anesthesia and intensive care in their practice. Now, today we have two eminent speakers with us who will be talking on these topics, and I'm sure all of us will be benefited by their lectures. We'll take your question answers at the end of the session of the two talks, and we'll try to solve all your queries related to these topics. Now, so not wasting much time, I would like to introduce the first speaker for the day, that is Dr. M. Shashidhara. Yes. And now he's working as associate specialist anesthetics in UK. After passing his basic qualifications from India, he did MRCA and MA in medical education. His areas of interest include trauma, regional anesthesia, ultrasound, difficult airway, and anticoagulation. He has done a lot of work in these fields, and besides that, he holds many other roles like chairman, HEENW CESR champion group, Member of Health Education England, International Medical Graduate Committee, and so many other. He is associated with the Stockport NHS Foundation Trust, WWL NHS Foundation Trust, and Edge Hill University. He's a director and instructor, Stockport ATLS course. He is an educational supervisor, international training program, among other positions. Besides holding many membership of various societies, he is a member of SAS Advisory Group, founder and secretary Northwest Pre-operative Network, first SAS member of Manchester Medical Society. He's a member of Education Board and LNC, Stockport, and Manchester Simulation Network. He is a recipient of many awards like Innovative Runner-Up Award AGBI 2014, SAS Conference Award for Innovation and Service Development 2016. So we are privileged to have such speaker with us, and I will now hand over the session to Dr. Shashidhara. Sir, I think your mic is, please unmute your mic. Yeah, thank you.
So, thank you, Dr. Singh, for that very kind words and kind introduction, and very nice to see you. And thank you, Sriganesh, for introducing to this webinar. And very nice to see Dr. Sriganesh from NIMHANS is part of this. It's been very nice and sunny in Manchester. We just gone for a limited lockdown yesterday night, but the temperature is 30, and the 30 temperature is unusual in UK. and I think I'm delighted to be here. I'm just going to start sharing my screen first. So I think in addition to what Dr. Singh said, I think my main role has been over the years now is a pathway lead for MAD in regional anesthesia, which is a program, second commonest program, which comes under global medical program. So I have, I think most of my time, 2 days in a week, I just spend on that. So today's talk is about anesthesia consideration for fractured neck of femur. So what I intend to do over the course of the next few minutes is to talk about a little bit about what is epidemiology of fractured neck of femur, hoping that I'll bring the perspective from UK as well as in India. Mainly I share my experience of anesthetizing patients with fractured neck of femur because I've been a trauma anesthetist for some time. And why fractured neck of femur is so important, because we consider it as a major public health emergency. And importance of pre-op assessment, management, and golden hour. It doesn't mean the first hour, but a golden time in terms of wanting to try and get the patient into theater and operate on these patients. Of course, I'm going to spend some time on the anesthetic management, post-op care, and rehabilitation. So if you Google it, there are so many reports, several reports about fractured neck of femur. So I've just got one of the report from Asian audit, cost and burden of osteoporosis in Asia. Similarly, we do have a joint collaboration of Royal College of Physicians, Royal College of Anesthetists, Public Health England, and various different organizations talking about national hip fracture audit or the database. And we also within that sits our national hip fracture sprint audit of practice, which is led by the Associate of Anesthetists and the Royal College of Anesthetists. If you look at that, there are fractured neck of femur becomes one of the major health issues. It's a public health issue. That's why it needs a major plan in terms of handling it. So I actually have a first question. So can I just find out from the people who are attending percentage of osteoporotic fractures in Asia by year 2050 would be? Any guesses? Sanish, I'm happy for you to share the...
Yeah, the poll window is on. Be nice if all of you put your answers. Yeah, another 10 seconds, we'll close the poll. Yeah, fine. I'm ending the poll now. This is the result.
Right. The option C is the right one. By 2050, we expect the number of fractured neck of femurs in Asia would reach about 50%. That means any anesthetist in India or any part of the world probably won't escape anesthetizing at least one patient every other day. In fact, it might go up even further. So if you look at this is one of the diagrams. So if you can look at what's happened here is that, let me just get one of these. Yeah. So this is the number of fractures which is in the West US as compared to the Asian people who are having the fracture. But what is important in this both charts is that number one, the number of fractured neck of femurs are going up is because India is no longer a developing country. It's actually almost developed country. So obviously some of the countries around Asia, Brazil and things like that, that they have already nearly developed, and the number of people surviving beyond the age of 60 plus is increasing. Obviously, number of osteoporotic fractures increase. Women tend to have more osteoporotic fractures than men, but unfortunately, the men seems to die more than the women. The mortality is far higher. So if you then look at the population prediction in India, by 2050, the population in India is going up. And then the population in India in terms of the people who are over 50 is increasing substantially, far more than the total population. So if you look at the graph on this side, you can see the number of people with a fracture neck of femur is going up quite steeply. So if you look at this number of patients who've been seen by the orthogeriatrists in UK, so with the number of patients who've been seen, and we estimate that we need to have every patient should be seen by orthogeriatrician in the first 24-36 hours. We seem to be reaching that. What I also did was I'm looking at my own practice in terms of, so this is my own logbook. So this is 1994 when I was in St. John's. I hardly did any cases. Because of my increasing amount of work with education, the number of cases I'm doing is come down. But if you look at the number of cases which I'm doing, which are fracture neck of femur, is going up. So I only do 1.5 days of anesthesia, Monday morning and all day Wednesday. They're all in trauma. I don't come home without anesthetizing at least a single patient with fracture neck of femur. Many times I would say I would have anesthetized 4. During the COVID, I'm probably anesthetizing about 2 patients every week. So every anesthetist will have some patient with fracture neck of femur. If you are a general anesthetist or a trauma anesthetist, you would be anesthetizing them. So this is the next chart is about mortality. Mortality in terms of how things are in UK. So this is overall performance. Currently the mortality of fracture neck of femur patient is about 6.1% over the last 2 years. But before 2010, our mortality were around 10 to 15%. And that is mainly due to, if you can look at the top one, we would not operate on these patients. We only would have operated on majority of the patients over 48 hours. So we worked on that. What the national audit has made us do is to learn from this data, also knowing that when we decide, if you're going to decide to operate early. So majority of the patients are now getting operated under 36 hours. So hence the mortality is around 6%, which is a good one to do. This is my own hospital, Stepping Hill Hospital. So as you can see, we did have some issues in 2012, but subsequently we got better. So we did have, despite operating early, we did have more mortality here, but we're still within the national average, which is good. Nice to be in that. So I'm just going to go a little bit further. So the important message to take is mortality and morbidity depends on the duration of the time the patient waits. So it's important, we need to consider that. The question number 2 would be, worldwide 30-day mortality of fracture neck of femur. So what it would be, is it 5 to 6%, 8 to 10%, 12 to 15%, 20%? This is worldwide, I'm not asking for UK.
Wait for another 10 seconds because nothing much to think. Fine, I'm ending the poll. So this is the response.
Okay. The answer would be, as of last 2 years, yes, some of the people have taken the answer as C, but the answer is B, which is 8 to 10%. Yes, if you are about 2 years ago, we were around 12 to 15%, but it's about 8 to 10%. So currently we see about 70 to 75,000 patients with fracture neck of femur in UK. We're talking about 147 NHS trusts across the whole of United Kingdom. The 30-day mortality, as I said, is about 6.1% over the last 2 years, 8 to 10% in the last 2 decades. It's important to know that 1/3 of the patient will die under a year, no matter what you do. Men die more often than women. But the single important factor is if you delay an operation more than 48 hours, that double the risk of post-op morbidity and mortality. That is due to increasing chance of somebody developing a chest infection, bed sores, urinary tract infections, unable to mobilize. So all these things, and the DVT, not to forget the deep vein thrombosis, that's what the reason for that death. So that's important to know. So if the decision is made to operate early, not late. But it's also sad reality is that 10 to 20% more women die than in their expected age within the first year. And that is even more so in men. And most of these deaths are not due to fracture neck of femur per se. It's possibly due to the chronic illness that they have been on. So most fracture neck of femur will have some or the other morbidity of some sort. Many a time the hip surgery is not curative, it's more often a palliative, a pain relief procedure. Surgery, however, surgery is the best painkiller, and if you can get rid of the pain, if there is any chance of survival, that's what it will give. And it's also important not to forget these elderly gentlemen and women who've been the citizens of life, who have been able to bring up you and me to the world, who also should have some dignity and painless death if they are need to go from this world. That's important to consider. So question number 3 here. Following are the common morbidity related to fracture neck of femur: dependency, institutionalization, lack of mobility, recurrent breast sores and urinary tract infections, and all the above.
I request all the participants to give you a choice so that we'll come to know how the audience feels. That's one of the ways we can overcome this disadvantage of this webinar platform, that the faculty and the audience, we don't see each other. Audience is seeing the faculty, but faculty is not seeing the audience. So you can put your response so that we'll come to know how you think. Okay, another 5 seconds. I am stopping the poll. Please hurry up. Yes, I'm stopping the poll.
Right, you're all right. So the option E, all of the above, is the right answer for this. Dependence, institutionalization, lack of mobility, recurrent source. I could add more things to that, but most important things, and we don't think about these things. This is a busy slide, but the important thing to remember is the function impairment expected in older people does happen because of several reasons. One is a fracture neck of the femur, but we also need to think about the vertebral and distal fracture. You might wonder why the distal fracture, because that can cause significant malleolin and other things. But the context of this to India is especially the women who maintain the home, who also control the home rather, also do things. They do become very dependent. 7% women become dependent on the basic activities of daily living, and it may go up to about 15%. And the dependency is a significant burden, and it goes up, and that's more so common in hip fractures. You just also need to remember a lot of the patients with fracture neck femur already have inability to walk, especially if they are 75 plus. They either have a Zimmer frame or some kind of walking aids here in UK, but that can go up to about 50%. And in fact, I would say half of the people will not be able to walk independently or will need some care. And they also need additional care. But what on top of this does cause effect on not just the individual, especially in nuclear families, in joint families in India. It causes depression on the individual, depression on the whole family. It can actually have an impact on their own family life, because healthcare in India is expensive. It's not like the state doesn't do that. So that's important to think about. So let's just move on a little bit further in terms of what is fracture neck femur. So fracture neck femur, there are various different varieties. I'm just going to, the main important thing to remember is intracapsular and extracapsular fracture. In extracapsular fracture, there are various different basal, trochanteric, subtrochanteric. In fact, if you can look at these, we'll come back to this again after it's another question for you, because this is important in terms of managing this patient. The following type of fracture, neck of femur, is least likely. Sorry, let me say that again. The following type of fracture neck of femur is least likely to be associated with significant blood loss when present in isolation. The choices are undisplaced intracapsular fracture, displaced intracapsular fracture, undisplaced extracapsular fracture, displaced intracapsular fracture, or subtrochanteric fracture. Over to you, Sanish. Yeah.
We'll have another 10 seconds. I'm closing the poll. This is the result.
Right. So we'll come to the answer of this. The answer is undisplaced intracapsular fracture is the answer, which is A. That's the one. So I will tell you why. Right. If you look at this diagram, undisplaced intracapsular fracture, the vascular tract is still intact. There's hardly any displacement. In fact, the intracapsular area, first and foremost, the intracapsular fractures don't bleed much. It's a lot of avascular tract. So among that, the intracapsular undisplaced fracture is likely to associate with the least amount of blood loss. The subtrochanteric usually bleeds a lot more, but it actually also associated with shaft fracture of the shaft of femur. Many times it does have a second fracture. So we're going to spend a little bit more time on immediate care and preparation. That's important. Pre-op assessment and management, and first 36 hours. How are you going to deal with the challenges for operating these patients? Then a little bit about anesthesia management, post-op care, rehabilitation. So I'm going to take on all these things together. So this is a little bit of a flow chart on what we do. Patient with suspected fracture neck femur in the emergency department. So remember when I said that care of the fracture neck femur patient start with the patient coming to the hospital. You need to be thinking about how do you take this patient to theater under 36 hours. So there are a few things we need to talk about. The first and foremost thing, I'm going to spend a little bit more time in analgesia, but before that, crucial step, we need to get this right, and then we are a winner. So the first and foremost thing, question is, we need to establish the patient, all the things we do the patient happen simultaneously. So that means the patient does get good hydration, appropriate analgesia, assessment of frailty, assessment of risk of fall. But the most important step is, this is when you decide, are we going to operate or not? I'm going to say this because a fatal fracture neck of femur patient will show signs of dying in A&E. You will know if you look at that from a distance, they're not going to survive. So, but there are very few of them like that. The majority will survive for some time. Yes, majority patient may not even leave the hospital, all those kind of things. But if you decide, you need to operate early. If you want to get reasonable result, operate early. So that's one of the crucial decisions. The other important things is identify the potential reasons for delay. Fortunately, the anesthetic reasons for cancelling a fractured neck of femur in UK is less than 4%. The most often it is the comorbidities, decision about should we have an echo. I think the biggest one even today is patients on anticoagulant medications. I'm going to spend a little bit more time on that. And the other important thing about is looking for fitness. So you got to remember, the moment a patient walks through the A&E door with a fractured neck of femur, they are unfit. It is very difficult to get an ideal patient to take them for surgery. They'll be, so what you have to make a decision is, what kind of medical condition can we optimize within 36 hours? Do we need to do that? Or does optimization has to happen simultaneously? And get on with it. So analgesia, very important. Simple humanitarian reasons for acute nursing care, important. If you want your patient to be looked after, you need to have the nurses, so for acute nursing care. And it also improves the patient well-being and reduce the risk of delirium. So one of the key problem for looking after fractured neck of femur patients is they develop post-operative delirium, post-operative cognitive delirium dysfunctions, and you need to avoid that. And it also facilitates return to mobility independence. Of course, what I'm saying here is, it is not easy, it is challenging, because they can come with different kind of comorbidities. It's very difficult to assess the need of analgesia when the patient are laying still. And there is wide variations in terms of how sensitive they are to opioid analgesics. Of course, they will need pain relief during mobilization, CT scan if you are looking at x-rays, and subsequent mobilization later, because you need to get them off the bed as soon as possible to reduce the chance of getting a chest infection, reduce the chance of them getting a DVT. But even more bigger problem is 30% of the patients have some degree of cognitive impairment, or they may have Alzheimer's, or they may also have some kind of expressive dysphagia, which also makes difficult to assess the pain. But the bottom line is, pain relief is important if you want to go in terms of treating them. So what you're going to do? Again, another busy slide. Offer immediate analgesia. As soon as they come, the first thing they need to get some paracetamol. Assess pain every 30 minutes. If the paracetamol is not sufficient, put them on paracetamol every 6 hours, unless it is contraindicated, offer other kind of pain relief. So I have been involved with training our A&E senior nurses and doctors in performing fascia iliaca block. I did it in between 2008 to 2012. You would see there's a big drop in the number of patient dying. One of the key reasons is getting them to have a facial echo block. As soon as they come, suspicion of fracture neck femur, facial echo block. So they will, facial block, advantage of using no blocks is they offer better pain relief. They don't require open analgesics. They don't need sedatives. And you suddenly everything becomes easy. And we offer facial echo blocks every 8 hours. So they will not only get the block in A&E, they also get another one if there is a delay. But if there is a delay of surgery for some reason, if the patient has got a complex fracture, which does require a specific specialist hip surgeon to do it, then we do put a facial iliac catheters for pain relief for these patients. So it's important. So it's also important not to put them on non-steroidal anti-inflammatory drugs because most of the elderly patients do have significant renal disease. So it's mainly paracetamol, blocks, plus opioids. We use OxyContin, which is oxycodone, slow release twice a day, plus for breakthrough pain relief, we use Oxynorm. So next question is, the most common comorbidity in patient with fracture neck femur. I've already told you that fracture neck femur will have some other comorbidities. So what do you think is the commonest one? Is it respiratory? Is it renal? Is it cardiovascular? Is it diabetes mellitus? Or they have cancer? Or do they have some disorders related to CNS? What do you, Sanish?
The poll window is there. We are actually expecting the single best response.
Yes, that's right. I want the single best response.
So another 10 seconds, we'll close the poll and get along with the discussion. Here's the result.
So 21% said cardiovascular. The cardiovascular is the most common. It's no matter which part of the world you are, the cardiovascular is about 31% of the patients with fracture neck have some kind of cardiac disease, more than that in some part of the world. Right. If you look at this, this is the one which comes from the sprint audit. Hypertension, commonest. So very common. Ischemic heart disease, 30%, which I said earlier, can be demented. And that is what was in anesthesia. So this is in the last 2019 database. And this is from the Trent audit 2014. I think it remains the same. Again, hypertension being 55%, very common. But more important thing is, along with that, is they also have other issues for communication. One is dementia. They also have repeated falls, but these two other things which makes things even more difficult: hearing loss, vision loss. 70% of the patient will be ASA 3 and 4. I think over the probably last 8 years, I have not anesthetized a single fracture neck femur who is less than ASA 3. So I do about 20 neck femurs every year. So at least 35% have at least one morbidity. If you leave the hypertension alone, they still have that. 70% have two. I think anybody who is more than 70 will likely to have at least 5 different comorbidity, because what we don't remember is we do forget about other things, frailty, people being have other minor illnesses, which also have some contribution to all these things. Anemia is very common. Transfusion trigger. So if they got some anemia, so you need to think about 9 or 10 based on the presence of ischemic heart disease. Leukocytosis and raised CRP is very common because of the response to trauma. Platelet counts, 50 platelet counts of 50 to 80. 50,000 to 80,000 is a relative contraindication, but we need to think about risk and benefit. I'm going to come to that when we're talking about anesthesia and analgesia per se. Any patient with a platelet count of less than 50 will need some transfusion before surgery, platelet transfusion. Electrolyte abnormality is very common. Chronic hyponatremia. They will have chronic hyponatremia because of the various medication they are on. Don't try to chase chronic hyponatremia. You need to base a chronic hyponatremia based on how awake, how they are. But you will have patients with chronic hyponatremia, but they also have got severe Alzheimer's disease. It's very difficult to correct the total loss of bodily salt. And they are on powerful medications like diuretics, which make them chronic hyponatremic. In terms of the ECG abnormalities, commonest arrhythmia we see in UK is atrial fibrillation. So we are looking at more of a rate control rather than rhythm control. It's very difficult to get them back into sinuses, but you need a rate control, reasonable rate control before you proceed. They may also have acute coronary syndrome, which may be the primary reason of their fall. So the judgment have to be made whether we operate or not. Patient will come with acute coronary syndrome. You still have to operate on them because the delay will still kill them. Presence of a heart murmur echo. So there are a lot of controversy around echo. When would you ask for echo? Do we need an echo? But tendency is in the last 10 years is to not wait for an echo. If you don't have a facility to get an echo, assume the patient has got the worst form of aortic stenosis or ischemic heart disease, unless you have somebody who's in acute pulmonary edema or somebody who's very breathless. You don't wait for an echo. You just put an artery line, get on with the procedure. So there are certain times when you might think about having an echo when they got inherent left ventricular failure and you have somebody with severe aortic stenosis, which is on the record. You waiting to make a decision whether you should operate or not. But nowadays, we are able to get echo done under 36 hours, still operate in them. Most elderly patients will have sclerosing aortic valve, very common, very commonly seen. They may have degree of aortic stenosis. More often, you will see a calcified aorta or aortic stenosis. COPD, carpulmonale, and chest infections. They may, if they are from the institute, if they have recurrent fall, they may actually present themselves with chest infection and then fall. So to what degree would want to wait to treat them or to operate, it depends on how they are. You just need to pick up the right kind of anesthetic for these patients. They will be on at least 20% of the patients who present fracture femur will be on some kind of antiplatelet or anticoagulant medications. We'll come to that in a second. Diabetes, renal disease, Parkinsonism, very important thing because these patients have Parkinsonism, and Parkinsonism medications are very, very important key things. And patients with Parkinsonism, if they got Lewy body related Alzheimer's or Parkinsonism, you need to be careful about when you're using antiemetics or benzodiazepines. They can have severe depression with those medications. They will also have peripheral vascular disease, osteoporosis, atherosclerotic disease. Significant number of patients would have either survived a cancer or have some degree, some kind of cancer still being treated. Nottingham's hip fracture score. This is a good score to use. It doesn't mean it is not, it doesn't take in consideration everything, but it can give you some chance of able to document 30-day mortality for these patients. But what it also gives you is a chance to use it in terms of when you're talking to the patient relatives. But you may not agree. And many times I put fractures in score from the Nottingham, and I do differ from the score because many times Nottingham fracture score underscores the patients, but it's important to document that. And it's also important that if you can document it, it's far more easier for you to defend yourself medically if there are any medical legal problems. And it is a good guidance and for in terms of developing a service, making things better. Very simple to use. So the score is on this side. It's available. It's also available as a in the app called Risk Prediction for Surgery. You can download it and you can very quickly work out what the Nottingham hip fracture score is. So it's also important at this point to think about other things. We told you about all the other things, but the sealing decisions. We don't stop operating on fracture neck of femur patient. Majority of patients, 98% of the fracture neck of femur we operate. It's very rare that we don't operate on somebody. But we do have sealing decisions. Decision about ethnical considerations. What would you do? What kind of limitations you're going to put yourself in? So are you going to resuscitate them? Right. Do not resuscitate does not mean you don't offer treatment. You will still offer treatment, but you're going to put some kind of sealing decision about what you're going to do with these patients. So other important complex things, these patients are on many, many drugs, drug allergies, antiplatelets, anticoagulants. I'm just going to spend a little bit of time on these. The next question would be, the following are the anticoagulant drugs. I'm talking about anticoagulant drugs. Dabigatran, clopidogrel, Synthrom, tirofiban, rivaroxaban, and enoxaparin. You have more than one choice for this question. Sanesh, over to you.
Yeah, I think some of the options may not be familiar to our Indian audience.
That's exactly the reason I put it in, because these are coming in your way.
Yeah, another 10 seconds, we'll close the poll and carry on with the discussion. Yes.
Right, so I'm just going to, so dabigatran is an anticoagulant. It's a direct thrombin inhibitor. Synthrom is an anticoagulant, which is similar to warfarin. It's a vitamin K oral antagonist. Rivaroxaban is one of the new factor Xa inhibitors. Enoxaparin is Clexane, is a low molecular weight heparin. Clopidogrel and tirofiban are antiplatelet agents. They are not anticoagulants. Clopidogrel, tirofiban is an antiplatelet agent, which is intravenous. It has a very short half-life. We use it very rarely for somebody who's got a stent in to so that we can put them back on straight away afterwards. Right. Yeah, somebody. Yep, good. Let's go further. So vitamin K antagonist, we talked about warfarin. Other one is Synthrom, which I already said. I'm not going into the detail of that, but the vitamin K antagonist, they inactivate vitamin K dependent clotting factors. That's the important thing to know. So you also got dabigatran. So you got TR, that's a thrombin inhibitor. Anything which has got a XA except fundaparin are factor Xa inhibitors. So this is just a risk stratification about what kind of patients are, which risk of thrombosis. It doesn't really matter in a fracture neck of femur. We are trying to gather them and operate them, but they'll give you some kind of indication about what we need to do post-operatively. So anybody with a mechanical heart valve, especially mitral and old mitral valve, somebody with a atrial fibrillation with a high chart score and recurrent VT are high risk of thrombosis. Another question before we go further. The following are one of the accepted tests for assessing anticoagulation effects due to anticoagulant drugs. Okay. INR, international normalized ratio, prothrombin time, factor Xa level, dilute thrombin time, platelet count and platelet functional assay, bleeding time and clotting time, and TEG.
There are 7 options. I'm closing the poll in another 5 seconds time. Yeah, 70% people are answering. That's a good thing. So here's the response.
Right. So obviously it's a multiple choice. So we could have had, but it's good. The choice, the INR is mainly used for monitoring warfarin or vitamin K antagonists. Use factor Xa level. We don't use it routinely, but you can use factor Xa level for factor Xa inhibitors. The dilute thrombin time is reasonably accurate in assessing the function of dabigatran. The platelet count assay and platelet count and assay is used for antiplatelet agents. Bleeding and clotting times are useless for monitoring anticoagulation. TEG has very limited value in terms of specifically for examining the effect of anticoagulant medications. Right. So I'm not going to spend a lot of time on this, but the important to remember is that dabigatran is renal dependent, highest renal dependent. So you got to remember this because it also got a much longer half-life. Whereas rivaroxaban, abixaban, edexaban, most often elective surgery, we do it after 48 hours, where dabigatran may 72 hours. But majority of them after 24 hours to do a surgery under general anesthetic should be okay. If you were to use a regional anesthesia, we need to make sure appropriate decisions and monitoring is available if you have to use it. We do it sometimes. So this is just a little bit of a flow chart for what the trauma nurses do if they're on. This is part of our perioperative anticoagulation line in terms of managing patients with fracture neck of femur. So what happens if they are, so the crucial thing is to, if the patient is on, is on a warfarin, as soon as they come to A&E, think about giving vitamin K. Spot INR, vitamin K. If they got patients on a neuro-oral anticoagulants, 24 hours, we'd wait, but we just make sure they get operated next day. And also thinking about post-op management. So testing neuro-oral anticoagulants, PT, antigen specific, rivaroxaban antigen specific PT is available, not very accurate. It does give you whether, if the PT is prolonged, it says, yes, there is an effect of rivaroxaban. It doesn't give you a quantitative evidence. It doesn't give you answer whether you can stick a needle in the back. Not very accurate. Dabigatran APTT is prolonged, but the more often we use dilute thrombin time. If you got a normal dilute thrombin time, it's unlikely the effect of dabigatran is there. But fortunately for dabigatran, we do have antidote called proxapine, so we use antidote for dabigatran now. Yes, testing. So I already covered that, so I'm just going to move on further. Patient with stent doesn't really matter, but the important thing is if the patient has got a bare metal stent, up to 6, they have a high risk of stent thrombosis. Somebody with drug-eluting stent up to a year. So appropriate precaution has to be done. Minimize the stoppage of the antiplatelet agents. If possible, use tirofiban infusion and restart the antiplatelet agents as soon as possible. This is just a little diagram from the association guidelines about amount of time each drug can work, whether you can stick a needle in the back. So coming to the anesthetic per se, and I put operation under 90 minutes. It is not always possible because you may not necessarily have a hip surgeon doing the procedure, but the aim is to work towards operate under 90 minutes. We do have surgeons who can do a DHS or AIIMS under 35 minutes, but the positioning the patient for a DHS probably takes far more than the operative procedure itself. Hip erythroplasty, most surgeons do hip hemiarthroplasty under 90 minutes. But the crucial important thing is during the surgery is appropriate antibiotics, not overhydrating the patient using appropriate vasopressors, because a lot of the patient do go into pulmonary edema. Managing the blood appropriately by using tranexamic acid. Always use a regional block, whether you use GA or a spinal. Very important to use regional anesthesia and invasive monitoring. But remember, if you're going to use invasive monitor, do it before the spinal because you don't end up losing lot of time. So anything which you think about, if you are trying to use an invasive monitor, important to remember to put the invasive monitor before any anesthetic intervention is done. Appropriate duty prophylaxis using floater boots. Watch out for bone cement syndrome. Okay, another question. The most effective and safe regional block for analgesia for patient with fractured neck of femur. Okay, it's important to remember most effective and safe. Over to you, Sriganesh.
Yeah, that response window is there. I'll read out the options. Option A,
Fascial block, femoral block, adductor canal block, lumbar plexus block, quadratus lumbarum block.
Okay, go ahead. Yeah, now more people are answering. That's a good sign.
Sanish, am I okay with time?
Yeah, fine. We are slightly running short of ahead of schedule, but it's okay, sir, considering the topic. Fine, I am closing the poll now.
Excellent. 71% said option A. The fascial block is actually the most effective block because it does produce blockage of lateral cutaneous and obturator and femoral nerve consistently far more than femoral block alone. Right, I'm just going to see whether my color coding works. Let's see whether it worked. No, for some reason it didn't fire up. Femoral block, less superior than fascial block. Adductor canal block more often for distal femur fracture or knee injuries. Lumbar plexus block, contrast lumbar block are useful, very good, but they are unsafe for the reason there are one. It's not because of bleeding, because where they are going to put it. It's more often because of the unilateral sympathetic blood that produce and significant effect on the hypotension. That's the other reason. So fascial block, and it's we also think about fascial block being used by an anesthetist to be able to produce analgesia. So that's why fascial block is the right answer for that. So in terms of anesthesia standards, we have a hip fracture management guideline. I know some of the things which I already talked about is part of that, but I'm just going to concentrate on the anesthetic standards. So the various standards, we're just looking at each standard. Some of the things which I agree, some of the things we don't agree, there will be wide variation. Just going to spend a little bit time on that. Patient should be anesthetized by a consultant or a specialist with a similar clinical experience, and most patients in UK are anesthetized by a senior anesthetist. So that there's no question about that. Spinal and epidural anesthesia should be considered for all patients. I'm just going to examine that in a little bit detail. So I've just put spinal and epidural should be considered for all patients. Is there any evidence that spinal and epidural is better? Or spinal anesthesia should be anesthetized using hyperbaric bupivacaine less than 10 milligrams? Is there any evidence for that? Let's have a look at that. So there are various different RCTs. So this is number one. If you can look at the various different things which has been considered: mortality, length of stay, vomiting, acute confusion states, pneumonia, myocardial infarction, embolism. So if you look at the quality evidence, is pretty low. So this is a single study. That's my problem. Anesthesia for 1,031 patients in a single hospital, single setting. They say if these data are confirmed by other answers, intraoperative hypertension in this patient group may be reduced by simply expediting of administering more cautious general anesthesia, reducing volumes of subarachnoid local anesthetic. I agree with the first part, expediting administration of cautious general anesthesia. What I don't agree is the low volume local anesthetic completely, because the comparison is between 4 milligrams against 10 milligrams, and it's a single study. Okay, let's go a little bit further. Of course, intraoperative hypotension is frequent. The general anesthesia produce a greater systolic blood pressure fall than 30, again in a single study. Patient receiving more than 1.5. We don't have a surgeon in the UK who could do a fracture neck femur procedure with a spinal anesthetic dose of less than 2.2 mils. Difficult to achieve. All right, let's see. Okay. So this is a Cochrane review. So this is in 2001, but subsequently been also readdressed. Regional anesthesia may reduce number of early deaths after hip surgery, but more evidence is needed to establish if it is better than anesthesia. So there's no real evidence to say that it is better. Also, majority of people with fracture are treated surgically. It is good for pain relief. We'll go a little bit more. The same group of people, subsequent to 2016, we did not find a difference between two techniques, except deep vein thrombosis in absence of potent thromboprophylaxis. The studies, wide variety of clinical practices, they recommend having further randomizing control trials. Okay. There's no doubt about using the blocks. Inhalation agents are better. Hypertension should be avoided. Let's just go a little bit further in this. Whether general anesthesia is harmful. So this is a study, again, another review. General was a neural anesthesia in hip fracture patients. They looked at 30-day mortality. It was a meta-analysis. They looked at it. So they said neuraxic anesthesia associated with reduced hospital mortality and lethal hospitalization. However, time of anesthesia did not influence the 30-day mortality. Again, in need for further studies. So what the message is that, yes, it's important to be careful, important to understand these people are very frail, elderly, patient more prone for all kind of things. A single anesthetic technique does not. Yes, think about spinal as the first choice of anesthetics. But what's important is to remember is it's not a type of anesthesia, it's how and what kind of anesthesia, how it is done is far more important than what kind of anesthesia is used. So another evidence, this is the same group, so again coming back in 2017. High quality evidence shows that regional block reduces pain on movement within 30 minutes of block replacement. No question about that. But moderate quality evidence shows reduced risk of pneumonia, decreased time to fast mobilization, cause reduction of the analgesic regime. Potential reduced side effects like respiratory depression and reduced incidence of POCD could not be fully established. This is about purely about nerve blocks. Yeah, nerve blocks are good when compared to giving opiates. I'm going to go a little bit further. So just about a couple of things in terms of regional anesthesia and spinal. So I already said it doesn't matter what kind of anesthesia, how it is done. There's also something around using control ventilation, spontaneous ventilation. I will just tell you the views of the various anesthetists across UK. When we are faced with 25 to 30% of the patients who are got a degree of Alzheimer's, they also have stroke and swallowing difficulties. The biggest concern for the anesthetist is aspiration pneumonia. So majority of the people, majority of the anesthetists, even though the sprint audit suggested spontaneous ventilation, would prefer a controlled ventilation with regional anesthesia block. So they would put a facial echo block, general anesthesia with a tube, ventilate them, rather than using a larger mask and allowing spontaneous ventilation on a larger mask. They will do an endotracheal tube and a spontaneous ventilation on that with some pressure support. I think I'm near the end. So I think what the biggest difference which in the mortality is done because of the teamwork. The teamwork consisting of, it's important we remember that orthogeriatricians are very important part of this. So I'll come to that, why they are important. Get the orthogeriatricians involved early. So you can look at this because when compared to all the other patients, elderly patients, geriatric patients, surgery anesthesia makes a little bit. They are the biggest problem is their comorbidities that needs to be managed. So when you have orthogeriatricians managing the post-op, you can look at the mortality rate has come down. Okay, survival rate is better. Okay, but that doesn't mean that you're asking for orthogeriatricians to seeking orthogeriatrician opinion for fitness for anesthesia. And we're not doing that. The orthogeriatrician are given a specific questions. The fitness of anesthesia is still within the anesthetist. Fortunately, we have orthogeriatricians who don't jump in and start giving a fitness, start acting. So one of the important things is to remember to segregate that important roles of the orthogeriatricians. So what they need, you need to essentially tell them what do they need to do. So number one, optimizing their medications. Is there something they can do throughout the process of the post-op period to make patient care better? Also, not delaying the process. They still need to sign up to the fact that the patient needs to go into theater under 36 hours, not delaying by asking extra investigation, not delaying asking for an echo. In actual fact, they should actually help you in terms of saying this patient may not necessarily need an echo because the outcome is not going to be indifferent. It's important that orthogeriatrician is not acting as a barrier rather than a facilitator for the procedure. The most important contribution of orthogeriatrician is probably in the post-operative care. They also make your job easy in terms of talking to the family, putting ceiling levels of treatment, discussing the do not resuscitate the patient in case something were to happen, deal with the drugs, dealing with the request for echo and other investigations, and most importantly, in terms of rehabilitation, assessing the frailty, assessing the risk of falls, optimizing their post-operative anticoagulation medications. That's their role. I think ideally, if you can get a geriatric unit where the fracture neck of femur patients are looked after, that's best. But I think we have this kind of thing. But we have a very good dedicated orthogeriatric team. They're actually virtually in that ward. This is an integrated ward where the orthopedic, anesthetic, orthogeriatrician, we work together. And these are the things they focus on. I think in summary, what I've given you is a highlight about the need of treating fracture neck of femur as a public health emergency, and make sure, understand they are high risk of group of patients. You can't get them optimized 100%. If you are to treat them early, operate them early. That is the best form of pain relief. Minimal anesthetic intervention, using simple anesthetic interventions, quicker surgery, which will help in reducing the post-cognitive dysfunction, orthogeriatric and rehabilitations. A word about using regional anesthesia in patients on anticoagulants and antiplagial agents. A single shot spinal anesthetic is commonly used even in patients on oral anticoagulants after 24 hours, but it's based on how fit they are. If they are fit for general anesthetic, we still go ahead and do a spinal anesthetic. But what we do is ensure is they have appropriate post-operative monitoring available in case develop perispinal hematoma, and further intervention will be required. Touch wood, I have done several spinals in anticoagulant antiplatelet units. We have not had any issues. Thank you.
Thank you, Dr. Shashidhara, for that elaborate talk covering all the important clinical aspects of fracture neck femur. We are just running short of time. I would just straight away forward go to our second speaker before we take up the questions at the end.
Yeah, so, that's fine. Thank you.
So I now go on to our second speaker, Dr. Sriganesh, Professor in Department of Anesthesia, New Anesthesia and Critical Care, Neocritical Care at NIMHANS. Just a minute. Okay, so he has done his DM in Neuroanesthesiology and Critical Care and Fellowship at McMaster University, from McMaster University, Canada. He has got special interest in neuroanesthesia, neurocritical care, pain, and research. He is a senior person having more than 16 years of experience after his qualification in the field of anesthesia, and have got many achievements and awards to his credit. He is a secretary, ISA Karnataka, and past secretary of ISA Bangaluru branch. Has got almost 115 plus publications, scientific publications, various peer-reviewed journals, several chapters in books, and 6 research grants on his name. He has been invited faculty at various conferences. He is reviewer of many journals, and editorial board member of Journal of Neuroanesthesiology and Critical Care. He received ISA Proficiency Award 2018 and 2019, Best Paper Poster Award in London 2017. He received ICMR International Fellowship in 2016 and KPR Young Anesthesiologist Award in 2013. So with so much of experience, I straight away go to Dr. Sriganesh for the second talk, please. Over to you.
Thank you, Dr. Gyanendra, for the kind introduction. Am I audible?
Yeah, you're audible, please.
Okay. Yeah. my full screen is visible, right?
Yeah.
Okay. I think we are running behind the schedule. So with the permission of the moderator and thanking Dr. Sanish for this opportunity, I'll begin my presentation and plan to complete it in the next 30 minutes or so. Greetings from NIMHANS, Bangalore, and I'll be speaking on the anesthetic consideration and acute medical management of patients with traumatic brain injury. Briefly, I'll touch upon the burden of traumatic brain injury in India and acute care management pathway of these patients, and then mainly focus on three aspects: pathophysiology of traumatic brain injury, anesthetic considerations, and acute medical management. In acute medical management, I'll just introduce you to the Brain Trauma Foundation guidelines for acute care of these patients. So India is labeled as the head injury capital of the world, and that is because as per the estimate, we have at least 5 lakh deaths per year attributed to traumatic brain injury. That is a huge number, and that's why it's a public health issue. Remember that most of the patients who suffer from traumatic brain injury are young adults who are in the productive age group and provide economic support for their families. So apart from socioeconomic aspect, it is financial burden for the family and to the society as well. So the acute care pathway of traumatic brain injury, this is how we do it at our place. Most of the patients arrive from the scene of incident, either trauma, road traffic accident, or assault or fall. They brought in an ambulance, seen in the emergency department, triaged, imaged, neurologically assessed, and then if found appropriate for surgery, are taken up for surgery as early as possible if there is a focal lesion for surgery. Most patients with severe traumatic brain injury and many with moderate traumatic brain injury require intensive care management for monitoring and ventilation. And subsequently, they are shifted to a ward from which they are discharged either to home or to a rehabilitation center. Most of us would be guilty of being careless with respect to potential traumatic brain injury. And as this figure depicts, some of the common elements which contribute to traumatic brain injury are speaking on phone while driving, not wearing protective headgear, helmet, traveling or with more people than is legally allowed, carrying more weights which can lead to imbalance, and driving on the wrong side of the road. These are some attributes which can contribute to traumatic brain injury. When you talk of traumatic brain injury, there are 2 types of injuries. One is primary injury, one is secondary injury. The primary injury is the damage caused by initial impact, which can result in either skull fractures, contusions, hematomas, or diffuse injury. The severity of primary injury is a major determining factor for outcome, and most of these primary injuries are largely irreversible. So here comes the first question for the audience. I am told most of them are postgraduates, so it will be interesting to see. This is a simple, straightforward CT scan, non-contrast of the brain, and you can see one lesion there. Dr. Sanish, this question can be opened for polling. So again, 4 options. First is extradural hematoma, second is subdural hematoma, third is contusion, and fourth is depressed fracture. So you can type in your answers and then we'll know the results.
Yeah, we'll close the poll in another 10 seconds because it's a straightforward diagnosis. Yes.
Yeah, I think 50% of them have got it right. It's a subdural hematoma. The lesion is hyperdense as compared to the surrounding tissue. That's why it is acute subdural hematoma. It is a concavo-convex lesion, which fits into the diagnosis of subdural hematoma. And most often this is associated with underlying brain injury, and therefore the outcome is dependent on several factors like the duration of injury, the surgery, the neurological status at presentation, etc. So we'll move on to the next slide, and There's no question here, but this is another lesion, acute traumatic brain injury. You can see the hyperdense lesion, biconvex, compressing the surrounding tissue. There is a mass effect on the ipsilateral ventricle. You are not seeing the ventricle on the same side. There is midline shift. There is shift toward the opposite side. And this is the diagnosis is extradural hematoma. The third non-contrast CT brain shows hyperdense lesion in the frontal regions. So this is a bifrontal parenchymal lesion, is a contusion. It is associated with significant edema. If you can notice on the scan, there is loss of gray-white differentiation, and the cisterns are full. So again, significant brain edema is present. The fourth slide shows two images. One is the bone window showing a fracture, clear cut. Sometimes a thin fracture may not be visible on the brain window, and you need to take a bone window to appreciate that. On the left side, you can see that there is underlying brain injury as well. Most often, unlike other injuries, the ICP in these patients is almost normal. However, these patients need to be operated to prevent secondary infection. Meningitis is quite common in patients with open cranial fractures. The last of the image is here. Here you don't find any focal lesion nor fractures. This is suggestive of diffuse axial injury. You can see that there is significant ischemia setting in, and there is again loss of gray-white differentiation, suggesting significant raise in intracranial pressure. The only indication for surgery in these patients is when all medical measures are exhausted and ICP is refractory to the conventional management. These patients come for decompressive craniectomy. So we are done with the primary injury. So the secondary injuries start immediately from the time of impact. And most often they are a consequence of either intracranial or systemic or both insults. And these secondary brain injury also determine the outcome. And the insults that lead to secondary brain injury are largely preventable and correctable, and therefore should be aggressively identified and managed. Coming to the general assessment of patient with traumatic brain injury, the assessment and resuscitation should go simultaneously. Circulation, airway, breathing take precedence. One must actively look for any extracranial injuries that may accompany a traumatic brain injury, such as seen in the figure here, that is cervical fracture dislocation, long bone fractures, and there can be associated maxillofacial injuries as well. These account for about 10% of the patients you find extracranial injuries as well. And these also affect the outcomes as shown in this study. The mortality is higher as compared to isolated traumatic brain injury. And the reasons or risk factors for this are hypotension and coagulopathy. So here comes the second question for the quiz. Which is incorrect about the Glasgow Coma Scale score? The options are: first, maximum score is 15, minimum score is 0. GCS can be used for prognostication. It can be used to assess the severity of traumatic brain injury.
The poll window is on. Now you can start responding. The question is about incorrect statement.
So which is
about
incorrect
GCS.
about GCS? Yeah.
Yeah, almost 70% already voted.
Okay.
Another 5 seconds, I'll close the poll.
Yeah, I think agreed completely. The minimum score is not 0, and you can appreciate that in the subsequent slide. So most of them have answered it correctly. So there are two scoring systems shown in this slide when it comes to neurological assessment. One is on the left is the most commonly used, simple to administer, that is GCS, or the Glasgow Coma Scale score. It has 3 components: eye opening with a score from 1 to 4, verbal response a score from 1 to 5, and motor response a score of 1 to 6. So the total maximum score is 15 and the minimum score is 3. Patients who have a score less than 9 are considered to have a severe traumatic brain injury. 9 to 12 are considered to have a moderate traumatic brain injury, and 13 and above are mild traumatic brain injury. There are some limitations of using GCS for assessing and prognosticating in traumatic brain injury. Patients with endotracheal tube, it is difficult to assess the verbal response. And to overcome some of these limitations, a new scoring system has been advocated, that is the 4 score, or the full outline of unresponsiveness score. 2 of the components, that is eye response and motor response, are retained, whereas 2 new components are introduced, that is brainstem reflexes, predominantly pupillary reflexes, which are commonly assessed, and respiration, including intubation or no intubation. Coming to the preoperative workup, the first and most commonly done investigation in traumatic brain injury is the non-contrast computer tomography of the brain. Subsequently, if there are any extracranial injuries associated, patients will undergo additional imaging such as chest X-ray or CT spine, or appropriate investigation like abdominal imaging, limb imaging, etc. Among the hematological investigation, blood group, hemogram, renal and liver function, glucose and coagulation are commonly done immediately as early as possible, especially if the patient is being planned for surgery. The broad principles of intraoperative care are listed here. One is the rapid reassessment when the patient arrives at the operation theatre. The patient's clinical status might have significantly changed from the time of first assessment in the emergency room. It could have increased with resuscitation, or it would have worsened with increase in the size of the lesion. And so it's important that you reassess and document the current neurological status on arrival in the operating room. Second is resuscitation is often incomplete in the emergency room, and these patients are wheeled into the OT with incomplete resuscitation, and therefore the resuscitation has to be continued. Third, we have to facilitate early surgery, because most of these patients benefit from early surgery, and time is brain, especially in pathologies like extradural hematoma. Appropriate monitoring is required. You don't have to go for extravagant or fancy monitoring because of the time limitation and utility in the intraoperative period. Lastly, as anesthesiologist and perioperative physician, your aim is to maintain homeostasis of the intracranial and systemic systems. So what constitutes intracranial homeostasis? It is maintaining normal intracranial pressure, normal cerebral perfusion pressure, normal metabolism. It is not possible in a patient with brain injury. So your aim is to try to bring these parameters to as normal as physiologically possible in the given situation. So what you can do, these are some of the things that is done to maintain intracranial homeostasis. One is head end elevation, neutral neck position, smooth anesthetic induction and maintenance, mild hyperventilation, osmotherapy, anti-seizure prophylaxis, passive hypothermia. And if all these medical measures fail to normalize ICP, CPP and metabolism, as a last resort, craniectomy and elective mechanical ventilation is performed. That brings to third question. Which of the following is likely to immediately reduce ICP? 1. Hypothermia, 2. Osmotherapy, 3. Barbiturate coma, and 4. Hyperventilation or hypocapnia. Which will result in immediate reduction of ICP amongst the 4? These are very basic questions, considering that I am told most of them are postgraduates. So if there are very seniors, please ignore this. Yeah, around, oh, surprising. Okay, around 47% have answered correctly. It is the hypocapnia or hyperventilation can result in immediate reduction of ICP. Osmotherapy take time. Even the bolus dose of mannitol or hypertonic saline takes about 15 to 20 minutes. Hypocapnia is instantaneous. So why ICP is important? Why so much focus on intracranial pressure? So this study shows how a normal ICP and raised but reducible ICP and refractory ICP results in different outcomes. As you can see there, if good outcomes, that is severe, good recovery and moderate disability versus severe disability and vegetative state. If you look at that as an outcome measure, you see that if the ICP is refractory, there is odds of or likelihood of poor outcomes by about 7 times. So that is the reason why ICP becomes important, and it is easily measurable. But do not focus only on ICP and only on number. You have to gain more information from the ICP, and we have to manage the patient as a whole. For example, if the ICP is say 40, which is twice the normal range, upper limit of normal, but if the mean arterial pressure is 100, the effective CPP comes to around 60 millimeter mercury, which is fairly within normal range. However, if your ICP is less, that is 30, but mean arterial pressure is also less, say 50, the effective cerebral perfusion pressure is only about 20. Therefore, we have to look at the patient in totality, including systemic factors, and not just focus on brain or ICP. That brings to us our role. The primary injury is taken care by the surgeon, predominantly surgical evacuation. There are several factors that can contribute to adverse neurological outcome, and these are mainly managed by anesthesiologists and intensivists, and these are listed here. You have not only avoid hypotension or these factors, you have to correct them as early as possible and bring them to as normal range as possible, as early as possible. So the lists are, you should avoid hypotension, hypoxia, hypercapnia, hyperglycemia, hypothermia, dyselectrolytemia, hypovolemia, anemia, and coagulopathy. And anesthesiologists play a major role, as you all know, in normalizing these factors. So this is a common scenario of our patients in our OT. So we see that two important factors which determine secondary injury, that is hypotension and desaturation or hypoxia, are prevalent here. And why these two are important? Again, there is evidence to suggest that when no hypoxia, no hypotension is present, in severe traumatic brain injury, the mortality is about 23%. Whereas when both hypoxia and hypotension are present, the mortality significantly increases to about 55%. And that's why we should avoid and correct these two important predictors, hypotension and hypoxia, as early as possible. So what are the causes for hypoxia and traumatic brain injury? It is a depressed sensorium, which decreases the respiratory drive, pulmonary aspiration, lung contusion, pneumo or hemothorax, rib fracture leading to pain and inadequate breathing, pneumonia, and really neurogenic pulmonary edema. So management is simple: identify the cause and correct them. Supportive management includes oxygenation with high FiO2, intubation, ventilation, and PEEP titrated to the oxygenation. So what are the causes for hypotension? Again, blood loss, most often volume loss. Rare causes include adrenal suppressions, extracorporeal injury can conceal the blood loss, and rarely arrhythmias and cardiac dysfunction. Again, management of hypotension: identify and correct the cause. Fluids, blood products to replace the blood lost, and early use of vasopressor inotrope to maintain the cerebral perfusion in the normal range. So some examples, what can lead to hemodynamic instability are arrhythmias, mainly because of raised intracranial pressure, and there is always a dilemma whether to correct the hemodynamic instability or go for surgery. Again, that has to be individualized. About 10% of the patient with severe traumatic brain injury present with myocardial dysfunction because of neurocardiogenic response, and those patients who have cardiac dysfunction have poor outcome in terms of lower GCS score and longer hospital stay. So hemodynamic changes are quite oftenly seen during surgical decompression in TBI. For example, a patient with significantly increased ICP, to maintain cerebral perfusion pressure, the body response is to increase the systemic vascular resistance so that mean arterial pressure is increased, cerebral perfusion pressure is maintained despite the increase in ICP. However, after surgical decompression, there is rapid and instantaneous decrease in the ICP, which leads to decrease in systemic vascular resistance and reduction in the blood pressure. This is a common phenomenon. The more severe the ICP, higher the ICP, more the blood pressure changes that you will witness during surgery. So how do you manage volume or fluid? This is the often neglected area in traumatic brain injury, but most important and easily correctable. For surgery, we have to secure large bore peripheral IV access, which can help in rapid replacement of fluids. We have to appropriately assess the intravascular volume. Most often, volume depletion occurs either because of blood loss or use of mannitol, furosemide, etc., and because of the prolonged fasting period and vomiting, etc. So you need to use preferably dynamic volume indices such as IVC collapsibility or echo to assess the chambers of the heart, or pulse pressure variations. These give better indication of fluid status. Avoid hypotonic and glucose containing solution. Hypotonic includes ringolactate or dextrose containing solution. And dextrose can lead to hyperglycemia, which is independently associated with poor outcomes in neurological patients. Between crystalloid and colloids, the debate is largely settled. colloids are no better than crystalloids. Crystalloids are preferable. Amongst the crystalloids, balanced salt solution is preferred. So mannitol and hypotonic debate will come to that later. But at this point of time, I want to inform that when there is hypovolemia or hypotension, mannitol should be preferably be avoided. Hypertonic saline as a bolus and infusion is preferable. However, if there is hypernatremia, it's preferable to use mannitol in this situation. And the blood loss should be replaced because both anemia and hypotension can be disastrous to the injured brain. Now we come to the anesthetic induction proper. So what are the agents that are commonly available? Most often we use either thiopentone or propofol. We all know that it results in cardiovascular depression. Etomidate is a better alternative. It results in minimum hemodynamic changes, but remember that it can lead to single dose also can lead to adrenal insufficiency. And most patients with traumatic brain injury, at least those who have severe traumatic brain injury, have some degree of hypothalamo-pituitary adrenal axis imbalance. So in hemodynamically unstable population, very few, ketamine may be a better alternative regardless of its impact on ICP. So which drug is not important, but how you use them becomes important in anesthesia. Opioid and lignocard have minimal impact on intracranial dynamics. They significantly ablate the hemodynamic and ICP response to intubation and laryngoscopy. So this was one student thesis which was done at NIMHANS to estimate the propofol requirement at anesthetic induction using bilateral BIS. So here you can see that compared to the normal side, injured side, BIS values are lower, and compared to mild traumatic brain injury, the severe traumatic brain injury have lower BIS values. And if you look at the second table, which is highlighted, the propofol requirement comes down significantly as the severity of brain injury increases. So severe TBI patients require about only 1.4 milligram per kg of propofol. Next important aspect in perioperative management is airway issues. So there are several issues which are listed here. One is the raised intracranial pressure and the potential for further increase in ICP with airway management. Second is the full stomach. So these patients are likely to aspirate because of poor neurological status or sensorium. Third issue is uncertain cervical spine. If you are not excluded cervical spine, there is a potential for further neurological damage during airway management. And simultaneously, we don't know the airway status. We cannot assess the airway status. So we don't know whether the intubation is likely to be difficult, whether it is likely to take longer time, and if there are any foreign material like blood, tooth, or any foreign body in the airway. Other aspect is these patients, especially those who come for surgery, are having severe traumatic brain injury. It is associated with hypoxia or hypercarbia. Prolonged time for securing the airway can further aggravate hypoxia and hypercarbia, which is deleterious to the injured brain. And last aspect is patients are agitated most often because of either hypoxia or neurological injury. So you tend to give more of induction agent, which can lead to hypotension, cerebral hypoperfusion, and its adverse consequences. Whereas those patients who are hypotensive, you tend to give lower dose of anesthetics, which can result in significant hemodynamic and ICP response during airway management. So there is no best or safe technique for managing the airway. It depends on the urgency of the situation, the expertise, and the resources that are available at that point of time to manage that particular airway. Preferably, oral tube should be used because skull-base fractures might be present, and the nasal tube is therefore not advisable. There is a lot of evidence regarding manual inline stabilization and direct laryngoscopy. So that is the most preferred management technique for securing the airway with modified rapid sequence induction and with or without required pressure. So common agents to facilitate early intubation are suxamethonium and rocuronium. If the patient is already intubated, please check for the tube position, reconfirm the oxygenation and ventilation. Remember to minimize secondary inserts during airway management, which I already discussed. And when available, and if you have the necessary expertise, use newer gadgets like video laryngoscopy as a first option rather than as a rescue option. So these two figures show how cervical spine immobilization can be done in suspected cervical spine injury in patients with traumatic brain injury. One on the left is mills being given from the head end, and the second image on the right is from the foot end. And you can also see that the cricoid pressure is given and the intubation is performed. But remember that manual inline stabilization, cricoid pressure can increase the chance of failed intubation, increase the intubation time, and also result in poor Cormack-Lehane grades. So this aspect has to be remembered. And patients with TBI and cervical spine injury is quite common. About 10% of the patients have cervical spine injury. So as I mentioned earlier, video laryngoscope may be a better option. Along with that, gum elastic budgie, if you use it, is commonly available. These two simple techniques can prevent significant movement of the cervical spine and facilitate quick intubation in patients with traumatic and associated cervical spine injury. When it comes to monitoring, a standard ASA monitoring is sufficient in most of the scenarios. Invasive blood pressure monitoring helps in beat-to-beat hemodynamic monitoring and management, and frequent blood samples can be obtained. The role of central venous cannulation is limited, especially in acute surgical intervention. It can be placed in the intensive care unit. Peripheral inserted central catheter are better option, and they help in administering vasopressors and osmotherapy. Coming to the maintenance, both intravenous and volatile anesthetics can be employed judiciously. Intravenous anesthetic agents such as propofol reduce cerebral blood flow, cerebral blood volume, cerebral metabolism, and intracranial pressure. Volatile agents such as isoflurane, sevoflurane, desflurane decrease metabolism. However, they increase cerebral blood flow and intracranial pressure, especially when used beyond 1 Mach. Nitrous oxide preferably should be avoided as it increases the cerebral blood flow, metabolism, and ICP, and can lead to pneumocephalus as well. Opioids, as I mentioned earlier, has minimal effects on cerebral dynamics and should be preferably used. There is only one study which I came across in recent times which compared TIVA with inhalation, published from JIPMER, and they observed lower ICP in propofol group and lesser incidence of brain bulge or tight brain as compared to isoflurane, both at dural opening and at the end of surgery. So this is our own experience with the bilateral traumatic brain injury lesions. Intraoperative complications related to our anesthetic management include hypotension, which was seen in about 1/3 of the patient, 32%. And if you look at the outcomes, alive versus dead, mortality was significantly higher in those patients who had intraoperative hypotension. 9 out of 15 died, and transfusion requirement. These are the two modifiable factors. The first two rows, that is gender, female patients, and poor GCS at baseline, these are fixed. We cannot alter them. So at least those which are modifiable, like avoiding intraoperative hypotension, should be considered and managed. The last part of my anesthetic management is the postoperative recovery. The decision to extubate on table is crucial, and several factors determine the decision making. One is the preoperative status, severity of TBI, both on clinical examination and on imaging, cardiorespiratory stability, intraoperative brain status, availability of ICU and monitoring facility, and lastly, importantly, is the judgment regarding the likely course of the patient in the postoperative period. All these factors should be taken into account when you decide on extubation. Remember, most of these patients cannot report pain, and postoperative analgesia is also very important because of the nociception involved because of the trauma and injury, including extracranial injuries. Last but important is to have vigilant monitoring both for neurological and systemic parameters. The last part of my presentation deals with the acute medical care in traumatic brain injury, and I'll not go into details for want of time. I'll just focus and inform you what are the current guidelines for management of severe traumatic brain injury in adults. And these guidelines are based on the quality of evidence and the level of recommendation. One is given if the quality of evidence is high, as determined from systematic reviews and meta-analysis, or high quality randomized controlled trials. 2A is a moderate quality of evidence, such as poor quality RCTs and large observation studies, and level of recommendation 2B and 3 is based on low quality of evidence, such as case series and poor quality observation studies. So here I go. We have 18 components for which guidance is available, 3 for monitoring, 4 for thresholds, and 11 for treatment. So for monitoring, ICP is commonly done, and ICP guided care has shown to reduce in-hospital and 2-week mortality. Long-term outcomes did not show any significant difference. The earlier guidance where ICP should be monitored, or the indications for ICP monitoring, have now no longer been reproduced in the current guidelines. But for information, these are the indications. Abnormal CT scan in patients with severe traumatic brain injury is indication for ICP monitoring. And if the normal scan in severe traumatic brain injury, if two of the following three are present, at age more than 40, abnormal posturing, and BP less than 90 mm of mercury. For CPP monitoring, recommendation is if ICP is monitored, CPP monitoring is desirable as it decreases 2-week mortality. And for advanced cerebral monitoring, jugular venous oxygen saturation monitoring can be considered, especially if you are considering hyperventilation. So last of the question here, which of the following is not used for brain oxygen monitoring? 1, jugular oximetry. Number 2 is near infrared spectroscopy. Number 3 is partial pressure of oxygen in the brain tissue. And number 4 is cerebral microdialysis. I know it is dinner time. I'm happy that most of you are still continuing to participate in this webinar. So which of the following is not for cerebral oxygen monitoring? Dr. Sanish? Okay, I think a good number of people have responded. Yeah. So cerebral microdialysis is the correct answer. Most of you have answered it. So moving on to the thresholds. Now, there are thresholds for blood pressure, ICP, CPP, and cerebral monitoring. And the current recommendation is to maintain BP above, systolic BP above 100 mm of mercury for patients aged between 50 to 70 years, and for other adults more than 110 mm of mercury. ICP, it has been revised from 20 to 22 mm of mercury based on emerging evidence. For CPP threshold, it stays between 60 to 70, and more than 70 should be avoided for ARDS consequences. And for jugular venous oxygen saturation, values less than 50 should be avoided. Coming to the treatment recommendations, decompressive craniectomy is not recommended to improve outcomes. It helps in reducing the ICP and reducing the ICU stay. When it is performed, a large craniotomy is recommended, mainly for surgeons. So prophylactic hypothermia, no role, not recommended. CSF drainage can be considered to lower ICP. It's difficult to perform ventriculostomy in patients with traumatic brain injury when ventricles are collapsed because of the raised ICP. But when possible, it is the most effective method to bring down the ICP and also simultaneously monitor the ICP as well. And when CSF drainage is performed, it is better to perform it as a continuous technique rather than intermittent technique. Now, most favorite for discussion is hyperosmolar therapy. The guidelines only mention about mannitol in the dose of 0.25 to 1 gram per kg. Avoid if the systolic blood pressure is less than 90. Restricts its use prior to ICP monitoring to only suspected herniation and acute neurological deterioration. So now we have choice between mannitol and hypertonic saline. Preference is individual favorites. You can choose between Nadal and Federer. It's up to you, because the evidence is also equivocal. There is no clear-cut evidence of which is better, mannitol or hypertonic saline. So this is our own study. We had about 32 patients, and we did not find any difference in either ICP or CPP in the intervention period, or even long-term outcomes, mortality at 6 months and Glasgow outcome scale score at 6 months. So both are equal, hypotonic saline, and there are several meta-analyses also published subsequently after the guidelines were published, which showed no difference with regards to mannitol and hypotonic saline in bringing down the ICP. There are some small studies which favor hypotonic saline, but given the long-term outcomes which we look at in patients with traumatic brain injury, it makes no difference. However, like I mentioned earlier, hypotensive patient, please avoid mannitol, and if the patients who are hypernatremic, please avoid hypotonic saline. One of the reasons why hypertonic saline failed to bring about the desired effect is because of the urinary loss of sodium, and thereby preventing significant elevation in the serum sodium levels. And we all know that serum level should be higher to bring about osmotic effect in patients with traumatic brain injury. Now coming to the recommendations relevant for us, ventilation and anesthetics. Hyperventilation below a PaCO2 of 25 mm of mercury, especially in the first 24 hours for prolonged period, is not recommended. And if you are using it, please monitor some form of cerebral oxygen saturation. Coming to the anesthetic, prophylactic use of barbiturates to produce pharmacological coma is not recommended. It can be used to control refractory ICP to medical measures. However, ensure that hemodynamic stability is present before you start this. Propofol can also be used as an alternative to thiopentone. However, prolonged use can result in increased morbidity, especially cardiovascular depression and other metabolic syndromes. This was one study which we published recently last month, wherein we compare two commonly employed interventions, that is PEEP and manipulation of the carbon dioxide, on two commonly used outcome measures, that is ONSD as an optic nerve sheath diameter as a surrogate for ICP, and regional cerebral oxygen saturation using non-invasive near-infrared spectroscopy technique. And we found that the best combination to reduce ICP was a carbon dioxide level of 30 millimeter of mercury and a PEEP of 5, and the best combination to increase the oxygen saturation in the brain was EtCO2 of 40 and a PEEP of 10, which are both higher. CO2 is normal and PEEP is higher. However, what this means is that we have to individualize our treatment goals and treatment interventions. One size does not fit all for all patients. Coming to the other treatment guidance, steroids, this is the only intervention which has level 1 evidence, and the evidence is it is not recommended either for reducing the ICP or for improving the outcomes. In fact, it is associated with higher mortality. Other guidelines for nutrition include introduction of basic caloric requirement by 5th day, preferably using the transgastric jejunal feeding to reduce incidence of VAP. For infection prophylaxis, early tracheostomy is recommended. Povidone iodine oral care is not recommended as it can lead to ARDS, and we should consider using antimicrobial impregnated catheters for external ventricular drain for CSF drainage or ICP monitoring. Coming to the DVT prophylaxis, low molecular weight heparin or unfractionated heparin along with mechanical prophylaxis may be used if brain injury is stable and the benefit outweighs the risk of intracranial hemorrhage. Currently, the evidence is insufficient to recommend one particular agent or particular dose or the timing of performing the pharmacological prophylaxis. Coming to seizures prevention, prophylactic anti-epileptic drugs are not recommended for preventing late post-traumatic seizures, but they are beneficial in reducing early seizures. So, coming to the end of my presentation, evidence for some is very clear, like you can see on the slide on the top panel, especially for steroids, class 1 recommended evidence and level 1 recommendation. But what is relevant for us for day-to-day practice, such as for anesthetic management, the evidence is blurred or unclear. But where the guidelines are available, where evidence is robust, we should not make poor decisions. Like this person has a resource that is available for him to tie his shoelace, but he is not making that judicious decision. So we should avoid making such wrong decisions when evidence and guidelines are available. Lastly, follow protocols, follow the guidelines that are available, but use common sense. Guidelines suggest avoiding blood pressure less than systolic of 100 millimeter of mercury. That does not mean that 101 is safe for your patient. So use your own common sense, and the situation that warrants a particular intervention or management strategy. To summarize, traumatic brain injury is the leading cause of death, disability, socioeconomic loss, and major public health issue. Data is limited on anesthetic management. Therefore, focus is on preventing secondary insults, and both intracranial and systemic insults can lead to secondary injuries. Adherence to Brain Trauma Foundation guidelines and comprehensive acute care has shown to improve outcomes. So we should follow them where available. Lastly, I want to conclude with this slide. Take care of your head. Not everyone gets a replacement. Thank you. And I'm open for questions.
Thank you, Dr. Sriganesh, for a very nice and comprehensively covered management of TBI, along with all practical aspects of it. It's a vast topic and you have volumes written on it and you have covered it very comprehensively. It's very nice. The house is open for discussion. We have few questions for us in the chat box. Maybe I will like to ask them one by one.
Okay.
One question, first question which is being posted by someone is that what is the maximum INR that is cut off for spinal? That is for Dr. Shashidhara.
Done spinal up to INR of 2.2, I will consider. I've done myself, I've done spinal at INR of 2. This is a patient who came with a saturation of 80% with a chest infection, planning to do EG, and you suddenly turn up in the anesthetic room. The INR is far lower. So the important thing to remember is to have a discussion, having a discussion with one of my other colleague to agree. Also document the way you're doing it, because delaying the surgery for another 24 hours adds further complications, have an effect on that. And also most important thing is to, other than documentation, is to make sure the post-op handover is appropriate enough to for a neurological monitoring. If there is development of hematoma, appropriate intervention has to be taken. So this is one of those situations you will come across. This is not the only one I've done. I probably have done about 15, 20 of these, where between INR between 1.5 to 2. So that's, it's really a number really in terms of, if you look at the literature, there's not really much evidence for bleeding under 2.2. More than 2.2, yes, there is. Under 2.2, it is a gray area. So you need to have a sufficient clinical reason why you're doing it.
Okay. So you accept patients up to 2. I mean, from 1.5 to 2, you gray area, but then with for spinal, you take it up to 2 for your
well, I think is, if the patient is not fit for general anesthetic, that's what I will do. The first intention is still to do it with 1.5, but there are times when for fracture neck of femur, if it is any other procedure, I probably would not do it. The fracture neck of femur is in a specific one. Okay.
Fine.
I got another meeting. Can I take a couple other questions, which is there, if you don't mind? And then I can. Sorry, Sriganesh, I took your time as well.
No issues at all, sir.
Next question is role of lignocaine 2% injection on reducing pain. That's put by again for Dr. Shashidhara.
Yeah, lignocaine is challenging to use in elderly group of fracture neck of femur patients. One, because of the various different kind of cognitive impairment. You also need to think about something which will work a little bit longer. And role of lignocaine infusion for orthopedic surgery is still not been studied extensively. Yes, lignocaine infusion we use very commonly in gallbladder surgeries, visceral surgeries, not gynae surgeries we do, but not necessarily orthopedic. So I won't. I just have to wait. So I haven't got much experience in terms of using it. I would prefer to use a facial echo block than lignocaine infusion.
Another question is use of PENG block.
PENG block, again, we're thinking about effective against the safety also. Here, there is another one, the surgeon's comfort. If you tell the surgeon, I'm going to go very close to the capsule, he's going to not going to love me at all. There are surgeons where they would not even allow facial echo block because the same sheath block, it will go very close to the capsule of the hip joint. So one, yes, it is effective, far more effective. There have been a lot of studies which is coming out of that. One is that higher risk of bleeding, far more risk of failures. The success rate is not as good as facial echo block, even though the people climb. The biggest one is probably, I want to be friendly with my surgeon. I want the patient to have pain relief. So that's the thing.
One more question which has been put. Have you come across any case of BCIS? What measures you take to prevent it?
Yes, BCIS is quite common than what people think. A lot of microbiology do happen routinely. People don't. Especially if you're doing a general anesthetic for a patient, you would see the CO2 trace going up and down. But fortunately, the dangerous syndromes are rare. I myself, I come across one in 2002 when I was doing hip replacement, where I had to take the patient to intensive care for 24 hours. Patient survived without any problem. In terms of preventing, fortunately, the surgeons are far more aware of this nowadays than before. Important thing, one is using a femoral plug before they cement it. So they put a plug in. Second one is to use a catheter in the femoral canal and not to pressurize the cement, and also have a WHO check first in terms of identifying the most sickest patient, where would you consider cementing or not. So if they are cementing, be gentle not to pressurize it, and be watchful, and it'll happen. But fortunately, fatal one I have not come across in the last 32 years yet. There's one where I had to take the patient to ICU.
Okay. And another last question for you is there any increase in DVT or pulmonary embolus in fracture neck femur patients who are COVID positive?
Very interesting question, because we are looking at it. So we are actually, this is something which we are still looking at it, early stages to say. I don't think we have seen, but there's an audit going on. Hopefully I'll be able to report on that. It will be probably published by my orthopedic colleague with one of the geriatrician. However, what I can say is we have seen between March and July, we have seen more spinal anesthetic being used than general anesthetic because of COVID reasons. We also seen early rise in mortality a little bit. So next year we will know a bit more than specifically in terms of, because I sit on the thrombosis committee of the hospital. So I've just been to the thrombosis committee meeting 2 weeks ago. We have looked at the data until the end of April. We not come across any increased incidence of DVT or PE in fracture neck femur patients.
Okay.
Okay.
There's one more question just now put up by someone's: hyperbaric bupivacaine 0.5 versus isobaric bupivacaine or levobupivacaine. Which one you would like to prefer?
We don't use levobupivacaine for spinals here. My use of hyperbaric or isobaric vary between the patients. It depends on how I can get. So having said so, I do use plain bupivacaine, which only happened on Sunday when I was doing the trauma list last week. The gentleman who had polio in the past. He also had significant amount of Parkinsonism, considerable amount of rigidity. Very difficult to position him on the side. So I essentially have to do the spinal with the normal side up. So I use isobaric. I do use isobaric. Doesn't matter. What is important is the volume you use. I don't use any more than the maximum volume I use is 2.4 mL of spinal. I tend to stay between 1.8 to 2.2.
Mm-hmm.
If I'm using isobaric, I probably use 2.4. I slightly use more volume because the spread of isobaric can sometimes vary.
Okay.
When
and there is one thing
heavy, I go towards the lower dose.
Okay. And one more question: unilateral or bilateral spinal with 1.5 ml would be okay?
Hyperbaric, unilateral, but isobaric you can't really control. So that's why the volume does.
Right. So I think these were the questions for you, Dr. Shashidhara. Thank you so much.
I just have to jump out to another meeting, I'm afraid. So thank you.
Thank you very much for
sorry,
your
I can't hear the discussion from Sriganesh. And thank you very much for all of you for giving me an opportunity. And those people, all the attendees, sorry that I kept your dinner late. Kept you late for the dinner. I did come out see Dr. Professor Saroja Sharma on the panel. So thank you, madam, for joining as well. Thank you. Bye.
Thank you very much, sir.
Thank you, Dr. Shashidhara. And now a few questions for Dr. Sriganesh. One of them: pain relief for decompressive craniotomy. What is recommended?
Okay. So it is a multimodal analgesia. For decompressive craniectomy, you can perform skull block, which provides good local region analgesia, reduces the systemic analgesic requirement. Add co-analgesics. You can add dexmedetomidine in low dose, paracetamol, non-steroidal anti-inflammatory drugs, and of course, the mainstay is opioids. But if the patient is already operated for focal lesion and later on the ICP increases and comes for decompressive craniectomy, then or for any other intracranial surgeries, better to avoid skull blocks. You can perform them with systemic analgesia. Anything you want to add, Dr. Gyanendra?
No, similar thing. We also practice the same thing here.
Yeah, I think this is multimodal analgesia, basically.
Yes, multimodal analgesia, that is what is preferred. Then hypertonic saline dose they want to ask.
Yeah, so hypertonic 3%, what is commonly used in India, at least in our center, is 3% saline, and the common bolus dose is 4 ml per kg. And if you are giving infusion, it can be between 10 to even 30-40 ml per hour. How do you titrate? Well, it is basically on ICP, blood pressure, and serum sodium levels.
As per your clinical experience, which is the best induction agent in TBI and why? That is one more question.
So I already mentioned in my presentation, don't choose which, choose how. So that is relevant for any aspect of anesthesia, any drug that you choose. However, since my choice is being asked, I prefer to use the conventional thiopentone in low dose, 3 to 4 milligram per kg, titrated to hemodynamics. Etomidate is a newer agent. Some of my colleagues do use that. But what I have found is, despite maintaining the hemodynamics, it's very good with respect to that. But if you look at the brain oxygen saturation, there is a potential decrease in brain oxygen saturation despite maintaining blood pressure. And that is the subject of research by one of our students. So we'll get to know the results once they're completed. But yeah, my choice would be still thiopentone in low dose.
Would I just put one more thing? What about ketamine? What do you think about ketamine in this scenario?
Routine use for all traumatic brain injury surgeries? No. If the patient is hypotensive, yes.
Right. Okay. Role of awake fibrinotic intubation in TBI.
One more thing before I go to the next question is, most of these patients have tachycardia and hypertension. Very rarely they will have typical hypertension and bradycardia. So there is a reflex mechanism, protective mechanism to maintain the cerebral perfusion pressure. ICP is high, so blood pressure is also high. So again, ketamine may not be a good option, but of course, when hypotension is there, it is a good agent. So the next question was regarding awake fiber optic intubation. Short answer, no. Reasons as follows. 1, time. Preparation is required for awake fiber optic intubation. You don't have that much time. Second, airway may not be clean. It may be contaminated with secretions, blood. Fiber optic, not a good choice. Third, awake fiber optic intubation, definitely it will increase ICP, coughing, agitation, movement, time taken for intubation, everything will be late. So these are the reasons why I would not prefer awake fiber optic intubation.
Right. Another question is, do you give tramadol post-op? Also, do you give morphine intra-op?
Yeah, first intra-op, we use predominantly fentanyl. If the patient is planned for elective ventilation, transitional analgesia is given using morphine because it acts for a longer period and maintains hemodynamic stability better as compared to fentanyl. Tramadol, if the patient is going to ward, is one of the option which is used. Yes, is tramadol.
Right. And another question is Lund theory concept.
Okay, so I did not cover that for because it's more of it is theoretical, but the Lund concept focuses predominantly on ICP, and you use clonidine, beta blockers, etc. for ICP management. And Rosenberg concept predominantly focuses on CPP, cerebral perfusion pressure. So there are two different approaches for managing the ICP. Currently, both are not preferred, at least it's a combination of both, I would say, which is important. Maintain a good, these are all old hypotheses, old concepts. Currently, you maintain a CPP of between 60 to 70 and ICP less than 20 or 22. So that any concept or any theory which results in the end result of ICP and CPP management into a desired level is good enough.
Just one more question has been put regarding our last answer regarding tramadol. Tramadol precipitates seizures. So that is what they want to ask.
Yeah, tramadol also induces vomiting, and patients with raised intracranial pressure patients are prone for vomiting. But I said one of the option. Okay, so if rather than using an opioid in the ward like morphine, I would use a tramadol. Seizure potential is there. You are giving prophylactic anticonvulsant, and it is easily manageable. EDH, seizures are more likely if it is a parenchymal trauma like contusion rather than EDH. So again, you have to individualize. You have to use your knowledge to appropriately use particular agent in particular scenarios. Potential of seizure is there. It is well-known side effect. So is vomiting, but we do use tramadol in select patients.
One question which has been put is propofol MCT LCT versus propofol LCT. Which is your suggestion when we are using an inducing agent?
I hardly use propofol, so I don't know. Maybe Dr. Gyanendra, your experience. I have no experience with comparison.
To be frank, I also do not have any comparison between it. And does it really make a difference? I do not have any idea about this at present.
It has got more to do with the. I don't think it has got anything to do with the intracranial dynamics, at least to my knowledge. I don't know if there are some seniors or who are more experienced using comparing both, they may add.
Because we have never compared like this as such. And lastly, one question is golden hour concept. They want to know about this.
Simple answer, short answer, as early as possible. Now, the concept of golden hour is more relevant in stroke rather than traumatic brain injury. Traumatic brain injury, I feel patients invariably recognize trauma which is visible. Unlike stroke, it takes time for family members, friends, or bystanders to recognize that there is some intracranial event. So the focus and education should be diverted to golden hour for this particular pathology. Traumatic brain injury, quite visible, evident. Nowadays, in fact, in NIMHANS, patient directly take 108, come to NIMHANS. Earlier, they used to go to a local PHC or a district hospital, then there would be significant delay. I don't think that is relevant now. I'm sure it is same thing in Kerala or in Delhi. People are aware, they know where to go for traumatic brain injury.
Now that scenario is changing actually. Yes. People are now coming earlier than what it used to be.
Yeah, earlier the time was lost because people would go to a center, maybe a taluka hospital, where there is neither potential for diagnosis because of unavailability of CT scanner or non-availability of neurosurgeon, and both are prerequisites for managing traumatic brain injury. Forget about other things like ICU and other mannitol or other agents, monitors, etc. But now the awareness is there. People know to consult directly super specialist rather than go through a primary care physician. This is my opinion. I don't.
No, that is true, absolutely. And one more thing is, what is your opinion about extubation and deep plane of these patients? Do you try extubation in deep planes?
Well, if you are, see, the purpose of deep extubation is to avoid any stress response, which can increase the ICP, and which is less likely in patients who has undergone surgery. If there is an EDH, large EDH evacuated, ICP is likely to be normal in this patient. Suppose the patient has parenchymal injury, raised ICP, intraoperative, brain is full, he would have undergone a decompressive craniectomy and bone would not have been placed back. So again, ICP high is unlikely. The problem with the deep extubation I find is the inability to assess the ability of the person to protect his airway, especially poor or severity of if the GCS is say less than 12, 13. I'm not sure whether the patient will be able to protect his airway, if there is airway obstruction, if there is any, because orofacial trauma, still there can be some blood which can lead to spasm later on. So I would still prefer awake extubation, at least a brisk M5 response, what we call, and good cough. If these are present, and of course the resources are limited, like we don't have an ICU for all patients, even high dependency unit for all patients, and I find that it is better or safer for the patient if he is extubated and sent to the ward because the level of care monitoring required is significantly less. We have had incidents in the past when, because ours is a government hospital, instead of putting the feed in the ICU, patients have put feed in the endotracheal tube. So, decisions are taken based on local factors. But simple answer to your question of deep extubation may not be advisable in patients with traumatic brain injury for the reasons I mentioned.
Very true, and this is what we also follow. Either we plan to ventilate a patient at the end of surgery. We should have a clear plan what we are going to do with it. Either we are going to ventilate a patient, or if we are going to extubate a patient, then better is to get him awake and extubate, as you mentioned, right?
Correct. Yeah.
There is one more question regarding blood transfusion protocols at your.
Honestly, we don't have a massive transfusion protocol in place, what is MTP. But a lot of corporate hospitals, and I think many other centers, I'm sure people in the audience will agree, have such protocols in place, which includes 1:1:1 or ratio, mostly of administration of, because these patients do have some coagulation abnormality as well, especially if they have some major extracranial injuries like pelvic fracture, long bone fracture, etc., abdominal injuries, etc. We don't get to see that kind of patients quite often. Very rarely we see multi-trauma patients. They don't come because our NIMHANS is a monospecialty hospital. They know very well that care is likely to suffer for other problems. But with regards to transfusion, some concepts important. One, early transfusion by appropriate estimation of blood loss. We have now point of care devices available to assess hemoglobin. And two is so the initial intraoperative period is very crucial. You have to maintain perfusion rather than oxygenation dependent on the oxygen content in the blood. So some degree of anemia is acceptable. You don't have to target it to full normal. And the priorities are different in intraoperative period. So the question was regarding what transfusion you do or what is the target?
Blood transfusion protocols.
Yeah. So we currently don't have a protocol in place, honestly. So what we do is individual decisions regarding transfusion. It's good to have a protocol in place so that everybody is clear, especially the residents, especially during the initial phase of their training. So what we do is we transfuse packed cells, we transfuse platelets if required. Otherwise, it is mostly FFPs if there is intraoperative diffuse ooze. The surgeon complains, mostly you don't require it for EDH again. It is predominantly for parenchymal bleed and those patients who are already on anticoagulants or have undergone some stenting or some kind of or stroke patients. These patients who come who are on aspirin or these patients require either FFP or PCCs, these kind of specific therapies. Otherwise, packed cell concentrate alone is sufficient. Maybe I would like to hear from other experts if what is their protocol, those who use massive transfusion protocol in their hospital. Anything in your place, Dr. Gyanendra?
Pardon, there's one more question is again target of this. Target hemoglobin, probably he wants to ask. What you keep for
if patient is hemodynamically stable, I would be happy between say 9 and 10. Again, these transfusion thresholds vary depending on several factors. Most of the studies consider ideal situation, but in real life scenarios, there will be several other factors that determine whether to transfuse, not to transfuse. But yeah, in general, I would not transfuse if the patient has say 10 and above. I would definitely transfuse if it is say 7 or 8, and then again individual choice if it is between 8 and 9, something like that. And provided hemodynamic stability is there and there is no active bleeding happening.
Yeah, that is what most of the places it is done like that, and probably the patient's condition, cardiac issues or something, yes. There may be secondary factors which can affect them. Correct. IJV versus subclavian versus femoral line. Any preference?
Well, no femoral. And between IJV and subclavian in the ICU, please remember these are not in the OT. There is no time for in emergency scenario. It is not required also. In the ICU at NIMHANS, we practice subclavian, but of late some of the new trainees prefer IJV with ultrasound guidance because it's quick and easy, especially when they are to do it in the wards. where monitoring is not possible and the support help is not there. But preferable choice between the three is subclavian. Reasons: one is it is easily accessible in hemodynamically unstable patients. Two, it does not theoretically impede venous drainage as compared to IJV. And three, most of these patients who undergo surgery for severe traumatic brain injury eventually land up having a tracheostomy in place, so you don't have to change places again. And four, it is more secure, more stable. It does not affect movement. So that way, these are some of the practical aspects why we prefer subclavian over other two.
Correct, correct. There are a few more questions coming up for you, Dr. Sriganesh.
Yeah, please. No problem. Dr. Sanish permits, then I have no issues.
Fine. Fine.
Okay, how do you manage fall in number after opening the skull is in EDH? Probably fall in number of hemoglobin. That is probably they mean. How do you manage fall in number after opening the skull in EDH?
What number?
I think the person must be talking about the fall in number or number maybe hemoglobin.
It's difficult to answer without knowing what it is. So if it is hemoglobin, it is we already discussed. How do you go about it? I don't know.
Hemodynamic attenuation measures to prevent stress response before extubation, like dexmedetomidine or something.
Yeah, you can use it. It is one of my favorite drugs, dexmedetomidine. Provided patient is hemodynamically stable, there is no contraindication. Remember, the decrease in heart rate can mask the potential bradycardia due to raised intracranial pressure in the immediate post-operative period. So you can use it for a short while to serve the purpose of ablating the stress response to extubation in low doses. Started a little early rather than giving bolus towards the end. I would because that will confuse the picture. So start it early once the closure start, low dose, and then you can have a smooth extubation. Lignocaine is commonly used. We used liberal dose of opioids, and I personally prefer to see that a patient breathe spontaneously and then cut off anesthetic agent. So that will prevent hemodynamic response rather than partial neuromuscular blockade recovery and inadequate respiration, and then you try to extubate because patient is coughing, bucking, BP is going up, like that. So these are some of the small steps which can be taken, practical steps.
Okay. Now that question has been clear. Now, how do you manage fall in BP, not number, after opening the skull in EDH? That is what the question is.
Yeah. So rather than managing, you have to prevent it. So before you know what is the cause. The cause is severe ICP, high ICP before craniotomy, which results in increased systemic vascular resistance, which leads to increase in mean arterial pressure to maintain the cerebral perfusion. So obviously, once the ICP drops immediately after craniotomy, there is going to be a corresponding decrease in the mean arterial pressure because systemic vascular resistance collapses or decreases. So I would fill the patient, maintain intravascular volume adequately right from the time I get to see the patient. So that will reduce the magnitude of fall after craniotomy. It is unavoidable, especially when the ICP is very high, drop is also likely to be proportionate. But filling the patient adequately, seeing that there is no significant blood loss, which can occur in trauma patients till the time of craniotomy, and replacing it with blood. So basically volume management is required to reduce the drop in. Other than that, any other artificial intervention is not desirable.
One more question is flexometallic tubes or normal for prone, especially in terms of need of post-operative ventilation. What is your choice?
Okay, the only traumatic brain lesion which gets operated in prone position is posterior fossa EDH or posterior fossa lesion. So where if you ask my personal opinion, that is again no evidence. I have done a lot of research on this for any neurosurgery in abnormal positions. I still prefer to use normal PVC tubes because if there is any increase in airway pressures during positioning, general position is to flex so that the exposure area is good. Craniectomy is easily possible. it can be detected during positioning. I can warn the surgeon not to do extreme flexion because it is producing results. And therefore, and it is desirable that you don't do excessive flexion. I prefer a flexometallic tube, and that same thing can be continued if the patient requires post-operative ventilation without having to resort to change in tube. Remember, most of the patients with traumatic brain injury come at odd hours. Most often junior persons, especially the trainees, especially in medical colleges, manage them with no help available. And trying to exchange the tube at the end of the procedure may not always be smooth, because prone position for long hours can result in airway edema. So extubation can lead to problems, even though you use an extubation, a tube exchanger or restriction guide. Second, flexometallic tube, these patients, remember, if you're not completely sedating them, they are often agitated because of especially pain, brain injury. All this can lead to agitation, and flexometallic tube can be easily be bitten. So it can lead to loss of ventilation tidal volume and also obstruction if the metallic component is bitten. It can lead to kinking and obstruction of that. So both can be disastrous. So I would still, my personal opinion is I use PVC tubes so that it can manage. There may be there are people I know who use flexometallic and change the tube. Both are fine as long as you know what the problems are with each technique.
Yes, but these things have to be considered while putting the tube, because if someone is at night available alone, then there can be problem. And we have almost lost 2 patients because of this, but somehow they were survived because there were help available somehow. But these are very scenarios which can happen anytime, right? One more, extubation ICU, is GCS above 8 recommended?
Pardon? Extubation above GCS 8?
In ICU, is GCS above 8 recommended? I don't think.
See, GCS alone is not a criteria for deciding extubation. All of us as our anesthesiologists and intensivists, we know what criteria need to be fulfilled. In addition to the standard criteria for extubation, in neurological patients, a sensorium is one of the component, and that to determine extubation criteria. It is an additional criteria. It's not the only criteria. So the patient has to be conscious. Patient has to have good cough reflex. Patient has to have good respiratory efforts. So all these rates should be regular. So these are some of the common factors you should consider for extubation, not just the GCS of one number or 8 or 9 or 10.
Yes, true, very true. Can we switch over to halothane if BP not controlled with SIVO or ISO, or we have to give propofol in between, or should we start beta blockers?
Okay, so multiple options given. I would not do any of these, beta blocker or halothane. So there are other better agents available. So you're using sevoflurane and you're going back to halothane, not advisable. And beta blockers, crisis, acute, some of them do use, but you should know what is the cause. First, identify the cause. Then only you can address the problem to its root. Otherwise, you are just applying Band-Aid, and which can be misleading. So beta blockers can result in masking of some of the protective reflexes in these patients. There are other agents available. You can use propofol. That is a good substitute because it is in the early phase of intraoperative period. No harm in using propofol. It is good cerebral protective agent. Also brings down the BP. So one of the suggestions that you mentioned, propofol, I would select that amongst other options you gave.
So 2 more questions. Any role of ketofol, especially in possible hemodynamic instability in TBI?
If you don't have other agents and you still want to use full dose, normal dose, then yes, combination of 1 milligram ketamine plus propofol may be considered. I don't do it.
And ideal time to start anticoagulation in severe TBI?
Okay, so what we do is not, I would say, correct. Considering the limitation that we have, what we do is mainly go for mechanical prophylaxis. But what is done is we perform a scan between 6 to 24 hours after surgery. If the scan does not show any expansion or of the lesion or a new lesion, especially most of the patients have multiple lesions also. One side will have EDH, one side will be contusion. So we have to perform a scan. And after 24 hours, between 24 to 48 hours, you can use pharmacological prophylaxis, either unfractionated heparin or low molecular heparin. But before that, use cheap, effective, and without any harm. That is mechanical prophylaxis. Right from the time of surgery, if you use it, is good.
Very true. And even guidelines do not suggest any time of specific timing of it. So you cannot
Correct.
just say, okay, this you start doing like this. It all has to be individualized depending on the condition.
Yeah, you have to identify the risk-benefit ratio, basically.
Yes, that is to be taken. So thank you so much, Dr. Sriganesh, for taking so many questions. They are
No problem.
I thank you. It was a very nice session. I am very sure everyone would have enjoyed it and learned a lot, especially the candidates who are going to appear in the near future for the exam.